Hi, everyone. Welcome back to our Beyond the Clinic Living Well with Melanoma podcast series. Have you ever wondered whether there is a genetic contribution to melanoma? How do we make ourselves stronger in situations that are not always within our control, like an inherited risk for cancer? We've got a special guest from the Cleveland Clinic, licensed clinical psychologist Dr. Karen Hurley, joining us today to help answer these important questions.
Oh, thank you so much for having me.
Dr. Hurley, you want to give an introduction to yourself and tell us what you do at Cleveland Clinic and how long you've been working in the field, thinking about psychological resistance and hereditary risk.
Sure thing. So I'm a clinical psychologist by training. I did my training at Temple University, and I have specialized in hereditary cancer risk right from the beginning. When I was a graduate student, I was working with an advisor who was partnering with a physician at Fox Chase Cancer Center, and they were just working on homing in on the mutations on the BRCA1 and BRCA2 genes that have become the foundation of clinical genetic testing. So I remember sitting in these research meetings, listening to the clinicians and the researchers talking about the choices that people have to make to reduce their risk. And I thought to myself, how in the world does someone know that they are at high risk for cancer? They maybe already have lost someone in their family to cancer or witnessed them go through a difficult illness, and then they're being asked to make decisions about protecting their own health. So that became my dissertation. And, umpteen years later, here we are. And it still is such a pressing question for so many people. So I've really felt it important to specialize in this area.
Right. So BRCA, most people think about related to breast cancer and ovarian cancer, maybe, but I think there is in some situations a risk for melanoma as well.
Mm-hmm. That's right. And I think that's one of the, if we think of hereditary risk as having a psychological landscape, that's one of the prominent features of this landscape is that when you test positive for one of these mutations, you're often asked to think about more than one cancer at the same time. And I know with BRCA2, there is research that has suggested a link between BRCA2 and melanoma risk, but at the same time that it's still equivocal. And so that's another feature of the landscape in genetics is that the information is changing as more research gets done, risks are clarified. And so sometimes people are acting on information because that's what's on hand at the time. And then things change down the road. So there's this burden of information, but also of living with uncertainty at multiple levels.
Yeah, I think the changes over time is so interesting because we don't know a lot still about what drives the hereditary forms of melanoma. And the other thing I would say is it's also harder in a way for our melanoma patients because when we think about melanoma, we think about sun exposure. And then how do you do studies with folks that are already getting sun exposure and what portion of that is related if your relative gets it, but they've had a lot of sun exposure. So I think in certain cancers, it could be really hard to differentiate a genetic or inherited component from an environmental one.
Mm-hmm. Yeah, that's right. And I think that it's important to acknowledge that sometimes people do learn about their risk after choices that they might have made differently had they known sooner. This can apply to being more assertive with some protective behaviors. It can also apply to things like fertility. So, for example, people who have a pathogenic mutation running in a family will sometimes choose to alter their plans for childbearing. Either they may have a smaller family than they were otherwise thinking about, or they may choose to use a birth technology such as pre-implantation genetic testing, which is using in vitro fertilization genetically testing embryos and then implanting only embryos that are mutation negative.
I see. I think there's even taking a step back before
Sure.
that, thinking about just how to disclose that and how to even find out about your family history, right? Because again, in familial melanoma, people think, oh, well, if you have two or more close relatives that have had invasive melanomas, you start thinking about familial components. But then how do you go about and ask your relatives about that? These things tend to be sensitive topics in families. And is there a right way to, in terms of disclosure about your own health, but also to ask those types of sensitive questions?
Yeah. And I think where I start with people when we're talking about family communication strategies is to spend some time reflecting first on the family's emotional climate, if you will. How have people in the family reacted to other forms of stress? Maybe other times that someone's faced a challenge or had to convey bad news, and how do people typically react, right? So, by the way, are we going to get some editing time in this? I should have asked sooner. Yeah, sorry. Okay, let me reset for a second. Okay, yeah, go ahead.
Yeah, so I think the question is just about disclosure and how do we think about how to ask sensitive questions in our family when these things are sensitive, whether you have a personal history of a cancer, but also to ask your family members whether they've had it to understand your own genetic risk.
That's right. So I think one of the things that's important is that people vary widely, even within a given family, about their comfort level about talking about these different kinds of sensitive topics. Another thing is that people are sometimes sensitive in particular to questions of blame, right? So asking someone about sun exposure, for example, might trigger some kind of defensiveness about what people have been or not been doing to protect themselves. People also will sometimes feel guilty about passing on a mutation. Even if you tell someone, once there's a mutation in the family, it's 50-50 for each given person, whether or not they're going to inherit it. And there's nothing that we know of that determines which way that's going to fall. People will still use language like, I gave that mutation to my child. And so that guilty feeling can also come up during these conversations.
I see. So when we have these feelings, how do we get past it? What are some things we can do to empower ourselves, empower our patients in our community to be able to get beyond that then?
I think the first thing to do is to view the conversation as a process, not a one-time thing. Sometimes people will sort of gear themselves up for one big conversation, whereas if you think about allowing conversation to evolve over the time, you give the initial amount of information, give people time to absorb it, give them time to have their feelings, come back and talk about it again. The first answer that you get with someone, like, oh, there's no way I'm going to go get genetic testing, might not be their last word on it, right? So this is a place where families are really challenged to be patient and compassionate with each other and to give space for answers to evolve.
Yeah, I like that. The conversation is a process, right? Because this is not just a one-time thing. It sounds like there's something that the individual has to work through, and over multiple conversations, perhaps get to a place. And because the evidence is changing, maybe you find out later that a relative has a similar cancer, then the pieces come together. So there's also a time component of these issues that you mentioned.
That's right, and it can also depend on when someone finds out about their genetic risk and what's going on at the time. So, for example, if someone gets a genetic test because they've just developed melanoma and they're only 32, then the family is wrapped up in the crisis of having someone who may be going through treatment, and then you've got the sort of conflicting agendas of attending to the relative who's going through the health crisis, but people thinking about their own risk at the same time. So that can be challenging to families. Another thing is when I first started working in this field 20 years ago, genetic testing typically went one gene at a time. So if you had a family history that was suggestive of a particular syndrome, like BRCA1 or 2, you would get that test and then maybe sequentially test for other ones. Nowadays, genetic tests often come in panels. You might get tested for 25 or 35 or more genes all at the same time. So sometimes what we see is that somebody gets tested because they are concerned about a risk of one type of cancer, and then they'll come up with a surprise result, which might include melanoma. And so your focus is in one direction, and then all of a sudden you're adding on new risks that may not even have clarified the risk that was the original question.
Wow, that seems like a lot to deal with in a short period of time.
Yes.
I feels like there's so much in what you just said too that I'd like to explore. I think the first part of it, and then we can get to panel testing, was really about the young age, right? Because hereditary risk often means that people get their cancer at a young age, and that by itself makes everything that comes after that very different. Because you're often dealing with different things than if someone had melanoma in their 60s, 70s, or 80s, for example.
That's right. Yeah. And I think there are 2 points in particular that are especially important. Number one, if someone is at a younger age and sees something that they think should come to the attention of a doctor, if they're younger, they may get dismissed or say, it's probably nothing, you're too young. This happens in a lot of different kinds of cancers. So especially if you're aware of a family history that is suggestive of cancer, then it's important to advocate and to ask for the appropriate level of follow-up and to keep at it. I think the other thing that's important is that when someone is either identified with as being at risk or going through treatment, is that all of a sudden there are things on the table that are not on the table for a person's peers. So typically someone in their 30s is thinking about things like partnering or building family, building career, pursuing education, laying a financial foundation, and they're not thinking about things like illness or even mortality, right? It's age appropriate for someone who's, say, in their 80s to be starting to think about what does it all mean? And, life does have limits, but that in some ways fast forwards people into a different age group beyond what their peers are thinking about.
Right. So what are the solutions to that then? Because we know, for example, only 8% of people with newly diagnosed melanoma have a first degree relative with melanoma, but in even a much smaller percentage, maybe only about 1 or 2% have 2 or more close relatives with melanoma. So it's not a lot of people with this. So even if you go to a melanoma support group, you might find, hey, I have these different issues. Where do you think people can get help from?
Okay. So first of all, I think it's really important that if anyone has even a whisper of a question in their mind, that maybe there's a family component, even if it's not very prominent with lots of melanoma, maybe there's lots of different kinds of cancers and you're not sure if that fits the definition of a particular syndrome or gene or not, is to go to a genetic counselor. What a genetic counselor will do is sit down and draw out what we call a pedigree, a family tree that goes 4 generations. And the genetic counselor can advise about what kind of testing would be appropriate, whether they meet specific guidelines for testing, and advise on things that may not have occurred to the patient, or in some cases to even a doctor who may not be used to looking at pedigrees for these kinds of patterns. So that aspect itself is really important.
I completely agree with you there in the sense that I think it's important to tell your care team. So I think as physicians, we think, oh, I don't know as much about genetics as my genetics colleagues, but I have a team. And that team is a genetic counselor. And so if the person brings it to our attention, then we can involve the right people in the right part of the team to answer those questions. That's great.
That's right. And I'm sorry, I was just going to say that living with since hereditary risk is, a something that you deal with over the course of a lifetime and over the course of multiple generations, that having a care team is really important. Having that sense of being in good hands and trusting your doctors, trusting the people who are keeping a close eye on you and advising you about risk management decisions, that's an extremely important part of getting through this and adapting to life with a hereditary risk.
Great. Let's pivot a little bit to the other thing you were talking about, which is these like full panel testing and what do we do with uncertainty of information? That's really in the oncology space right now. And I guess I'm going to make 2 points. The first point being, I think when I'm in the clinic and I'm having conversations, I think people do get confused between the cancer mutations of the cancer itself. In this case, for example, melanoma has BRAF mutations versus a germline, which is something that's inherited. For example, in melanoma, the CDKN2A gene. So there is a difference not only between understanding the actual mutations of the cancer itself versus hereditary, but then when there's other types of genetic abnormalities that are of what we call uncertain significance, or at least at this time we don't know, there's a lot of uncertainty about that. So how do we educate about these differences and then educate about the uncertainty, and how do we come to grip with the fact that there's so much uncertainty in the space?
Yeah, I think that's a really good point. And I want to start by saying, now, I am a clinical psychologist. I'm not a licensed genetic counselor, but I have to be able to speak a certain amount of genetic counselingese, right, in order to communicate with patients. And so I think one of the things that I've learned is that by being at least passingly familiar with, most of these basic distinctions, it means that when I do see a patient for emotional support, we don't have to talk about that stuff, and the patient doesn't have to spend time educating me about their risks or questions. Already knowing what's been put in front of them, we can go straight to, what does this mean for you? So with that said, it is confusing. And again, we want to look at risk information as a communication process in itself. So this distinction between what are the mutations that a tumor has gone through on its way to becoming a tumor, right, is different from the tumor that you, or not, it's different from the mutation that you were born with that set the tumor in motion. So that's one way of looking at it. So the language itself is not exactly user-friendly. But once we get there, and it's sometimes, I think in the melanoma space in particular, there's this testing of the tumor, and then you backtrack to finding out whether something was what we call in the germline or something that you were born with, right?
Yeah, that's a good point, because most people aren't thinking about a hereditary form of it because maybe they didn't know about a family history or wasn't suspected. And then when you do these larger panel testing in the actual tumor itself, you find that there's a proportion of that where they actually had a germline or inherited type of mutation. And that, again, that creates, it's sort of what you're saying, which is it sort of adds in a layer of complexity that a person wasn't expecting. There's like this idea of uncertainty and surprises, and it can be pretty distressing.
That's right. So when someone is undergoing genetic testing, like for a panel, and when I say genetic testing, I mean clinical genetic testing to find out mutations they were born with, right? That it's really important to go in with a sense of, what do you want the testing to do for you? how is this information going to serve you in some way? Excuse me. And then that puts you on a good footing for what happens next, right? If you know why you're doing it, then you want to be able to ride the sense of ups and downs and unexpected things that might be coming. But as clinicians, what that tells us is that we want to focus on the fact that we cannot always predict how genetic tests are going to turn out. We can't predict what people's reactions are going to be. So we want to, as much as possible, create a soft landing so that no matter what kind of information someone gets, is that we're ready to receive those reactions of surprise and uncertainty, and to help reassure someone that they will get their feet under them, maybe not right away, and that the team is going to be part of helping someone get their feet under them.
So I love that. I think what you're saying is, let's set some, if you have some expectations in education up front, that helps you create that flexibility to understand what the result could be potentially. Mm-hmm. So there is that communication and education piece that's very important.
Yes.
I want to dwell on uncertainty a little bit longer, because as a clinician, I feel that uncertainty very, very much in these types of cases. There's also these uncertainties from my end as a clinician, where I don't know in a way what to say when we get these results, because we don't have enough information on how we should change screening recommendations, or how we would change the management necessarily when there is a hereditary mutation identified. So what do we do about our surveillance recommendations when there isn't necessarily strong evidence to support a higher level of monitoring? Again, there's this uncertainty, right? I'm at higher risk, but nobody really knows what to do with that higher risk.
Yes. So again, I think part of the communication is to sort of acknowledge that the knowledge is in process of being generated, to be able to say openly, this is what we know so far, and things may change. So this is not necessarily what someone wants to hear, but being able to support someone in accepting that this is the best of what we have to offer. We'd like to we would like to be able to offer more certainty than this, but this is our best educated guess at the time with the data that we do have available. And that's on the communication end. But I think there's a more almost existential level, if you will, that we walk around in our lives with assuming a level of certainty almost, beyond what is actually true. We say things like, see you tomorrow, right? We don't say, see you tomorrow, asterisk, unless X, Y, Z happens, right? Right? It's too cumbersome. But we kind of get used to that being our reality. So one of the other prominent features of the genetic risk landscape is that it kind of strips away some of that everyday mindset that kind of buffers us between, our everyday functioning, and the reality is that we don't know what the future holds, but we have to navigate anyway. We have to make decisions anyway, and we are responsible for those decisions that we make. And that's part of the invisible heaviness, if you will, that people carry especially when they're first learning to adjust to what does it mean to be at risk. So it's almost like there are the people who have been exposed to this new level of uncertainty, which is the uncertainty that everyone has in their lives existentially, but doesn't necessarily process or face.
I'm going to try to summarize sort of what we've talked about so far, because I think there's been a lot. I think we're really talking a lot about uncertainty and of like how to deal with those kind of emotions, regain a sense of control, and what are sort of some of the special issues related to hereditary risk, like being young when you're getting your first cancer, or like even disclosing and discussing with your family members. And what I'm hearing is that, if acknowledgement, as with many of the things that we've talked about in this series, has been important. Acknowledging the uncertainty, acknowledging the limitations of knowledge, thinking about communication with your care team, in particular the genetic counselors, thinking about this as a process, that it's not just a single time point, but that information changes, and we need to do this over time and have these discussions over time, setting expectations in education. Those are all important things to move forward. Did I get that right so far from things we talked about?
Beautiful.
Okay. So I wanted to spend maybe this last segment really talking about how do we trust our own bodies and trust ourselves, because we might get information about a higher risk situation, but it doesn't mean that we still worry about sun exposure in the case of melanoma or other types of risk factors. And for example, I hear this a lot as a clinician, like, I am at higher risk. How do I trust my own body? How do I trust my own exam? And there's emotional components to that. Have you dealt with that in your research or in your discussion with patients? And what are some of the solutions that we could give to our podcast listeners today?
Mm-hmm. Yes, and I think it's a good question. And focusing on the word trust, it's almost like learning the risk information. Sometimes it's empowering to people. It helps them make choices or, change behaviors, but sometimes it can feel like a betrayal, right? So I think that, and this is one place where people are at their most individual, at that level of, what does this mean for me? So for example, someone who learns about their risk after, being an avid sunbather, as a teen, maybe this means I'm not young anymore. And so there may be some, resistance to adhering to the recommendations based on feeling like, well, that means I'm not me anymore. I'm not that fun-loving me, or, whatever that meant to them. And that's just one example out of many. Right? So that there are kind of layers of meaning to work through on the way to rebuilding trust, or to kind of cultivate a deeper sense of trust in the body.
And I think what I'm hearing too is you're almost saying that we have to relearn who we are, that we have to sort of rediscover ourselves, because there's been a change in ourselves, whether it's because of that information that we found out that there's hereditary risk, or and how do we have to go through that journey of self-discovery again? Is that what I'm hearing?
Yes. One of the things that I will often say to patients when they're coming in to see me initially is that learning about risk is like an earthquake that shakes the building. Anything that is strong stays standing. But anything that is either has a crack in it, or loosely bound, or weak in some way may fall over. So for example, someone who is a planner, that's how they cope with life. They like to have lists, they know where they're going, and then all of a sudden, you have someone sitting there saying, you're at risk for this disease. We can't tell you for sure whether or not you're going to get it or when that might be. And all of a sudden, planning is not possible, not in the same way. So it does kind of shake to the core of someone's identity. And what was it that made them a planner in the first place, right? Mm-hmm. So sometimes it sets off echoes into other parts of life that don't necessarily seem connected to the cancer or cancer risk, but wind up being connected by virtue of these layers of meaning that we bring to the table.
Right, and that's so individualized, because someone may be a planner or someone may not be a planner, and so that's where the personalization, individualization, and self-discovery come in, right? Because if I'm the opposite, then I have to come. Maybe the solution is something very, very different than if I am a planner.
That's right. Yes. So I think that there are there are these wide variations between one person and the next, and that's where we really need to be able to offer open listening space. But there are also several things that we know from psychology research that do enhance people's ability to cope with uncertainty and with hard times of all types. Social support is a really important one. We talked about social support at the level of interacting with a care team, but there are other things that people can do. One thing I like to ask is, do you have at least one person in your life to whom you can say anything and who can listen without judging? So you may have a huge support network, but if you don't talk to anybody, doesn't matter how many people are there. Other people may be socially isolated, but then if you can say, if you think about the people in your life, can you pick at least one who seems like they're a good listener? People you can usually identify someone, or it can be a prompt to start seeking that out.
I love that, because we keep on coming back to that in each one of our podcasts and each one of our, even in the webinar series, which is that social support is so important. The care team can do so much, but it's that day-to-day, the folks around you in your community, and to be able to seek them out and to find those listeners to help you work through those things.
Yes.
Right, because I guess what you're saying is, too, the self-discovery often requires other people to help us get there, because we need that sounding board. We need something to help us reflect back on who we are.
Absolutely.
That's great. So I don't know, we've talked about so many things. We've talked about really how to acknowledge the uncertainties of genetic testing and the differences between hereditary and acquired mutations, and how to seek our care team and genetic counselors, how to think about this as a process, and about education, and even about how do we sort of do the work of self-discovery. Are there things that you think are really prominent that we haven't talked about today that you think that you get asked often?
That's a great question. And in fact, that's something I often close sessions with. So I think one of the most important things is to talk about the nature of resilience itself. Right? It's a word that is used a lot more these days, because unfortunately we've all been challenged to become more resilient in the face of the pandemic. It sometimes is a feel-good word, and sometimes people take it to mean something that's inherent about you, something that, some people are naturally more resilient than others, and so it can make resilience almost feel like some kind of special power or something that's out of reach. So I like to think of resilience as in the words of another psychologist, Anne Maston, who called resilience ordinary magic. It's something that we all have inherent in us, but we don't really recognize it until we really stop to look at what the processes are. So, for example, think about if you cut your finger, things start happening right away. The blood starts to clot, a scab forms, the skin grows over, and pretty soon, at least in a cut finger, you can't tell that it even happened, right? It's so ordinary, we don't stop to think about it. But when we do, it's pretty magical. And we have psychological processes that kick in times of challenge that we don't really know are there until we need them, until we have that metaphorical cut finger. One of the most important is a natural shift that happens over time. When we experience a challenge, oftentimes one of the things that kind of hurts the most is all the things that we suddenly can't do or getting knocked off track. And then gradually over time, our vision shifts from what we can't do to what we can, what's still possible. Now, there's a level of uncertainty in that, because I can't promise any given individual when that moment is going to be. If you've ever seen those, what they call the Gestalt figures, it looks like two faces looking at each other. Oh no, it's a vase. It's a visual trick that our brains naturally do, right? You can't get someone's brain to do it, but our brains all do it. Same thing happens with resilience.
Wow, that is super powerful, because I think what you're saying is that, we always think maybe, oh, that person's more resilient than I am, but we all have that hidden capability that we need to unlock it. And maybe part of it is to say, okay, I can't go out and meet with people because it's COVID-19, or I can't go out in the sun because of this issue, but what can I do? And that, again, feels to me like a process, right? It's what you're used to be able to doing, but then you start thinking about, okay, now I can take control, and take control by saying what I can do. And that's very empowering.
That's right. Any person who's in the middle of cancer treatment will tell you that someone at some point has looked at them and said, "Oh, you're so strong," right? As if cancer picked you out for being a strong person. No, it's that the resilience processes have started to kick in, whereas that person may not have had that experience of resilience and doesn't understand that that's what they're capable of if life puts something like that in front of them.
Dr. Hurley, I think I could talk for hours about resilience with you, because you're such a wealth of knowledge, and it's been such an amazing conversation today. It's resilience for hereditary risk sounds like it could be applied for many of the other things we've talked about in these series. I want to thank you for your time, because time is our most precious resource that we have, and you've shared so much with us today. So thank you so much for your time today.
Oh, it's really been a genuine pleasure. Thank you so much for having me here.
Great. And I'd like to thank our audience for coming today to listen to the podcast. If you have liked our podcast today, you can find more along with our 2021 webinar series at aimatmelanoma.org in the Melanoma Learning Center. Thank you so much, Dr. Hurley, and hopefully we'll be able to speak again at some point down the line about these types of important topics.
That would be wonderful. Thank you.
Okay. Take care.